Hello again, ladies and gentlemen. This will be a talk on the patient with quote unquote chest pain. And I put chest pain in quotation marks here because not all of this pain is actually necessarily coming from the chest. It could be coming from elsewhere. Also, when we think about chest pain, we often think of cardiovascular causes. And not all of these causes are necessarily cardiovascular in origin. So, when you have a patient coming in, typically they come into the ER complaining of chest pain, you have to keep a whole host of possible diagnoses in consideration. You can't just jump right to cardiovascular causes. All right, so this is an update from a lecture that I gave way back in 2013. I'm updating it now, not necessarily to provide any new information because there's really not a whole lot, but really because there was a sound issue on a previous video, and so I'm kind of going through trying to address those. So this is to kind of fix that. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right hand corner, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free and coming. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, treatment plan, things that will come in very handy for you as you gear up to study for later steps of the USMLE, particularly step 3 with those clinical case scenarios, not multiple choice. You'll need to have a good systematic way of going about things. Thank you very much in advance for your consideration. So, how do you approach a patient with chest pain? Well, as we said, chest pain is one of the most frequent complaints in the ED. And I would say about half the time when a patient comes into the ED complaining of chest pain, it's actually reflux. It's very, very common. Reflux is very common, often mimics chest pain. It's very common in older people, and older people are very aware of chest pain and they get very worried if they have chest pain, and rightfully so, because heart attacks are a possibility. But most of the time, it's reflux. Nevertheless, you must approach these patients with the utmost index of suspicion, especially if they're older. A good general rule of thumb is that young patients presenting with chest pain without clear symptoms pointing to a non-cardiac cause, you should get an EKG first. So by young, I mean less than age 50. If they're older, meaning over the age of 50, then any patient presenting with what they describe as chest pain, you're going to get an EKG first. Now, in practice, if a patient comes in and they're complaining of chest pain, you're just going to get an EKG with anyone. Young, old, doesn't matter. However, when it comes to the USMLE, you should think EKG in all older patients with chest pain. With younger patients, look more deeply into their symptoms. Don't necessarily jump to an EKG. If you're taking step 3 with those clinical case scenarios, I would get an EKG no matter what on anyone with chest pain because it's cheap, it's easy, it's fast, and you can rule out something that could be catastrophic. As we already said, chest pain has a very wide differential, so you'll want to know your PQRST of the pain. That's going to be part of your history. And then any distinguishing physical exam signs, those are going to be essential. And USMLE step 2 and 3 are going to give you some distinguishing exam signs. They may say, 52-year-old man comes in complaining of chest pain, and then these other symptoms. And those other symptoms are going to be key in determining what the cause is. They may also give some of your PQRST features. So things like the pain goes away when he sits down, or it gets worse when he lays down, or it's throbbing, or it's tearing, or it radiates to the back, or it's been going on for 3 hours. Those are useful to know. So this is all part of getting a good history and noting any other symptoms, be they cardiovascular, GI, pulmonary, etc. So here's your differential diagnosis of chest pain. As you can see, it's very big, and I'm sure there's other things that could have been included here, but these are the most common and the most common to come up on the test. You can see there's GI causes, there's musculoskeletal causes, there's respiratory pulmonary causes, and certainly there's cardiovascular causes. There's also psychiatric causes. So we're not going to talk about these. I do talk about them in my psychiatry videos. Things like conversion disorder, where you essentially have these symptoms that you truly believe that you've got, but they're from a psychiatric origin. Factitious disorder, where the patient's kind of making it up. Often this is in consort with Munchausen syndrome. And then malingering, where they're coming in saying they got chest pain because they want a note from to miss work, or because they want pain meds. Very important, by the way, to know the difference between factitious disorder, Munchausen's, and malingering. Very, very important. But I talk about that in the psychiatry videos. Okay, so we're going to talk about the GI, muscular, respiratory, and cardiovascular causes. And I am absolutely not going to go into all of these disorders in detail, but I am going to point out some distinguishing features. I do talk about in the course of all my 400 plus videos. I do have videos dedicated to most of these, and certainly in the cardiovascular section, I do go into each of these things in particular. But I'm not going to go into the details of them. I'm only going to go over some of the distinguishing features so that when you have your chest pain, you're looking at it from 30,000 feet level, you'll have some ideas of where to go with your differential diagnosis. So first off, the PQRST of pain. Every second year medical student learns how to take a history, and when you have a patient with pain, you get your PQRST. So P stands for provoking and palliating. What makes the pain better? What makes the pain worse? So the patient may say it's worse when I eat, and it's better when I sit up, and it's worse when I lay down. So you want to know what makes the pain better, what makes the pain worse. Q for quality. How does this pain feel? Describe to me in your own words how this pain feels. And if they aren't really good at describing it, you can ask them, is it sharp? Is it dull? Is it burning? Is it tearing? How does this pain feel? Describe this pain. R for region or radiation, or referral. So where is the pain? Does it go anywhere else? Point to where this is. S for severity. Usually you have the patient rate it on a scale of 1 through 10, 1 being very, very, very subtle pain, 10 being the worst pain you've ever had in your life. Is it mild? Is the patient in distress? How do they rate the pain? That's all has to do with S, severity. You also want to know, does this pain oscillate? Does it come and go? That's going to be important as well. T for time. How long has this pain been going on for? Has it been minutes? Has it been hours? Has it been days? Has it been weeks? How quickly did it come on? Did it come on all of a sudden? Did it come on very slowly? Does it come and go? So that's your PQRST. Provoking, palliating, quality, region or radiation or referral, severity, and time. And this is just all part of your history. Now, not all of these things are necessarily going to be helpful to you, but when you have a patient with pain, if you put all of these things, you get all of these things as part of your history, you'll have a nice, good history of pain. And if you're a resident or a med student, your attending will be really happy with you that you have all this information. So some key physical findings for your diagnosis. First off, your initial impression. Is the patient calm? Are they distressed? Are they panic? Is the patient still or antsy? Typically, patients who have MI, they're going to be in a lot of pain. Whereas patients with maybe reflux, they could come in pretty calm and all right. And then, when their pain comes back, if they start feeling that reflux, then they may get a little bit more distressed. But typically patients with the more problematic things like pulmonary embolism, aortic aneurysms, and aortic dissections, MI, they're going to be distressed all the time. Vitals, you want to know your blood pressure, your heart rate, your respirations. Breath sounds, is it painful when they breathe? You want to notice that when you're having them breathe in and out, when you're listening to their lungs. Is this painful for you? Are their breath sounds asymmetrical? If their breath sounds are asymmetrical, you need to think of things like a pneumothorax or a pulmonary embolism. Heart sounds. So again, I go into all of this in greater detail in further in my other cardiology lectures. But things like S2 splitting. Is there any abnormal heart sounds like S3, which would suggest congestive heart failure. S4, which would suggest a left ventricular hypertrophy, which would be congestive heart failure or a cardiomyopathy. Or it could be an infarction. Is there a pericardial rub? That's this sort of frictiony sounding sound that you hear with your heart sounds. Can't really describe it. If you want to go on YouTube and look up what a pericardial rub sounds like, you could probably find some recordings. This suggests pericarditis, and you'll be told it's a pericardial rub or a frictiony sounding heart sound. And then look at their extremities. Is there calf swelling? That suggests a pulmonary embolism. Not because you don't get the pulmonary embolism because of the calf swelling or vice versa. Calf swelling suggests a DVT, and DVT can dislodge and cause a pulmonary embolism. So if you have chest pain in addition to calf swelling, that highly suggests a pulmonary embolism. An absence or asymmetry of pedal pulses suggests an aortic dissection, where you may not feel pedal pulses, or you may feel it more on one side than on the other. So some key symptoms for non-cardiac causes. So the big one is gastroesophageal reflux disease. I would say far and away this is the most common cause of chest pain in the ER. When you just are working in a community, you got someone coming in, a lot of times they drive themselves in with chest pain. Most of the time it's reflux disease. Look for a history of gastroesophageal reflux disease, but some other things that you may notice: the pain comes on after eating. They may get some relief with antacids. They often describe it as a burning sensation. This pain burns. It's not crushing, it's not tearing, it burns. It starts in the epigastrium and radiates up the chest. They may have a history of vomiting, or they may have a sour or metallic taste in their mouth. You may actually smell that. And if you work in the ER and you see enough patients with reflux disease, you develop a nose for this reflux smell. So one of the things that you'll do for reflux disease, of course, you may get an EKG because it's chest pain, but a lot of times give them a viscous lidocaine GI cocktail. And if that helps with the pain, then you pretty much have diagnosed reflux. Peptic ulcer disease can look a lot like reflux, except they tend to not have vomiting so much, more belching and bloating. And the big one here, a history of aspirin or NSAID use. Both of those things can precipitate ulcers and they can make it worse. The pain in nature and in origin is very similar to reflux. Just look for this history of aspirin or NSAID use. There's some overlap here. It can be difficult to diagnose one from the other, and really the only definitive way you can diagnose a peptic ulcer is through an EGD. But that being said, if you have a patient with chronic pain, history of ongoing aspirin, NSAID use, and they've got chest pain, peptic ulcer disease should be pretty high up in your differential. Cholecystitis. So cholecystitis is inflammation of the gallbladder. That's going to characteristically be right upper quadrant, but it can radiate to the chest and cause a patient to think they have chest pain. In your history, especially for the USMLE, look for the 4 Fs: fat, female, fertile, and 40. So, you got a 42-year-old woman who's still getting her periods, who's got a BMI of 29. Then you've got your 4 Fs already satisfied. Also look for a positive Murphy sign. So you apply some pressure right beneath the rib cage on the right side and have them breathe in. If they stop breathing and they wince in pain, you've got a positive Murphy sign, and that's pretty good for diagnosing cholecystitis. Remember, to definitively diagnose cholecystitis, you're going to need to, at the very least, get an ultrasound. And then esophageal spasm. In this case, a physical exam is really not going to help too much. You want to look at your history. These patients tend to have a history of dysphagia or regurgitation. A lot of times, though, this pain so closely mimics an MI that you're going to wind up getting an EKG, but that EKG will be normal. If you give these patients with esophageal spasm, if you give them nitroglycerin, a lot of times that's going to resolve the pain. In that case, you've got your diagnosis. A barium esophagram is going to be one of the better ways to diagnose esophageal spasm, but the problem is you can only diagnose it when they're actually having the spasm. When they're not having the spasm, you're not going to see anything abnormal. So costochondritis, this is fairly easy to diagnose. Costochondritis can be very similar to, the pain that you can get with an MI. The difference is with costochondritis, it can be replicated by pushing on the area where they describe pain. So a lot of times with costochondritis, it's point tenderness. So if you ask the patient to point where the pain is at, they will point with one finger. They'll point to where it is. And that's useful. If a patient points with their fist or with their hand, that tends to be a more diffuse pain. If they point with their finger, that's a point tenderness. And if you press on it, it's tender. And that's different from cardiac causes where you're not going to be able to elicit the pain. So costochondritis, you can elicit the pain by pointing on it, point tenderness. Not only that, but there may be a history of an injury. So maybe they were lifting things, maybe they went to the gym and did pec workouts. That can all cause costochondritis. If they've got some chronic cough or something like that, that can do it as well. So how about respiratory causes? Pulmonary embolism. This is a big one. So look for a sudden increased respiratory rate. Pulmonary embolisms come on very suddenly because you have a dislodging of a plaque, and then that embolus comes up and lodges then into the pulmonary circulation. So it'll be very sudden symptoms. They'll start to become oxygen deprived, so their respirations will increase. If you take their pulse oximetry, they may be lower. They may be in the 70s or 80s. They may have some respiratory distress. If you look at their extremities, you may notice calf swelling on one or both sides, usually on one side. And that is suggestive of the DVT. They may be a surgical patient. They may be pregnant, things that raise your risk of clotting. And then this pleuritic chest pain. So when they're breathing, it hurts. That's not going to happen with an MI, but it will happen with some of these respiratory causes. Another thing here with this calf swelling is something called Homan sign. And Homan sign is where you dorsiflex the foot. So you flex the foot up towards the leg, and that elicits calf pain. And that is fairly specific for a DVT in the calf. Pleuritis is pain with respiration, fever, rapid shallow breathing, and a scratchy sound and oscillation of the lung. Very similar in presentation to the pulmonary embolism, minus the respiratory distress. It's mostly just pain on respiration with some inflammatory signs. Rapid shallow breathing, not because they're hungry for air, but because it just hurts too bad to breathe deeply. So this is really going to be pain with deep breaths. So they breathe shallow but more quickly so they get enough oxygen. Pneumothorax is also going to usually be sudden, but what you'll get very characteristically is an absent breath sound on one side. So you'll be able to hear breath sounds on one side but not on the other. They may be slightly hypoxic. A lot of times there'll be a history of a rib fracture or a penetrating wound that would cause the pneumothorax, or it may be a spontaneous pneumothorax. In that case, look for young and tall patients who are at increased risk for spontaneous pneumothorax. Pneumonia, obviously, fever, increased white blood cells, crackles and rails on auscultation. All right, now what about our cardiac causes? So again, I go into all of these in later cardiology lectures, but the big one is angina. Angina is probably the most common cardiac origin cause of chest pain. And this is just acute substernal chest pain that when they sit down and rest, it gets better. So the pain comes on with exertion and goes away with rest. And it's very predictable. Comes on with exertion, goes away with rest. Unstable angina is just angina that doesn't improve with rest. And this is very concerning because unstable angina is very much associated with a future heart attack. Now, a heart attack, an MI, is the same as unstable angina as far as symptoms go. And they'll describe this pain as crushing, and that would hold true for unstable angina and angina as well. When just angina pain, ischemic pain of the heart is crushing chest pain. The only difference is with unstable angina, it doesn't go away with rest. And with an MI, it doesn't go away with rest, but then they also have laboratory signs. So if you get an EKG, you may see ST elevation. Or more specifically, if you get cardiac enzymes like your troponin and CKMB, those are going to come back elevated. So really the only way that you can tell an MI from unstable angina, aside from the patient dying on you, is to get an EKG and cardiac enzymes. Another useful sign is something called Levine sign. And Levine sign is where they point to the pain with their fist, not with a palm, not with a finger, but with a fist. And what they're really telling you is that it's a crushing pain. What do you crush things with? You crush things with your hand, and you make a fist when you crush it. Well, when they're pointing to their chest with their fist, that's Levine sign, and that's associated with MI. It's an old-fashioned way of going about things, but it's still done, and so that may be something to put in your back pocket for the USMLE and for your clinical practice. However, you're always going to get an EKG and enzymes if you ever suspect an MI. Myocarditis is chronic pain. So it tends to be very vague and mild, and they have a fever because this is an inflammatory process. Pericarditis looks a lot like myocarditis, but remember, this is the pericardium, that surrounding sac of the heart. And that sac can stretch out, and it stretches out when you lay down. So this is positional pain. So pericarditis gets worse when you lay down as that sac stretches out. When you sit up, that sac is kind of just sitting there all nice, but when you lay down, it stretches out. And so this is positional pain that gets worse when you lay down. Pericarditis gets worse when you lay down. It's also some pleuritic nature to the pain. So when you're breathing, you're expanding the chest cavity and you stretch that pericardium out. So this is also pleuritic in origin, similar to some of the pulmonary causes can cause that pleuritic chest pain. Pericarditis can cause pleuritic chest pain. It's sharp in nature, and they can get EKG anomalies. So some of those EKG anomalies include a diffuse ST segment elevation. You can get ST segment depression, however, in a couple of the leads, the AVR lead and the first precordial lead. Low voltage, so all of the voltages are going to be smaller, so you have less amplitude on your EKG reading. And then with time, they can get T-wave flattening and then ultimately T-wave inversion. So you'll see some EKG changes, some characteristic EKG changes with pericarditis. A dissecting aortic aneurysm has a very classic tearing pain, and the USMLE will like to throw that at you. It's an easy point. When they tell you tearing pain, it's tearing pain that's substernal and it radiates to the back. And that makes sense because the aorta, the thoracic aorta, is behind the heart, and so it radiates to the back. Mitral valve prolapse is a transient pain. It comes and goes. It could be. It usually is associated with the murmur of mitral valve prolapse, which is a mid-systolic click. It tends to be in females, and they tend to have a propensity towards anxiety. So look for a woman, maybe a younger woman, 20s, 30s, who's got a history of anxiety. She comes in a little anxious. The chest pain comes and goes, and when you do your auscultation, you hear a mid-systolic click. That's mitral valve prolapse. Okay, I just want to bring this one entity up. I do talk about our acute coronary syndromes in another lecture. That's your angina, unstable angina, and MIs. But I do want to talk about this one particular entity because it warrants some discussion, because it could be an easy point on the USMLE. And that's the inferior wall myocardial infarction. This causes chest pain, but it causes some very interesting other symptoms. So inferior wall MI is going to have all your symptoms of a typical MI. Sudden substernal, severe crushing pain, not relieved with rest. However, it can also have these other symptoms: bradycardia, diarrhea, and lightheadedness. These are not things that we would expect with an MI, and any other MI is not going to give you these things necessarily. So typically with an MI, your heart's not going to slow down, at least until you're about to die. And an MI is not going to cause diarrhea or necessarily lightheadedness. So why do you get bradycardia, diarrhea, and lightheadedness from an inferior wall MI? Well, let's look here. So it's important to know where each of these arteries cause an MI. And an anterior wall MI, as you know, is going to be caused from an infarction of the left anterior descending artery, particularly the diagonal branch. So right here. A posterior wall MI, and this is just for review, is also going to come off the left coronary artery, but that's going to be from the left circumflex. And the left circumflex can, an infarction there can also, if it's further down, cause a lateral wall MI, which I didn't label here. Now, all of those infarctions, they have to come off the left coronary artery. The right coronary artery, while it can cause a posterior wall MI, tends to cause the inferior wall MI, and that's right here, coming from the posterior descending branch of the right coronary artery. Now, when you have an inferior wall MI, because it's towards the back of the heart, it's in a particular location where, and here I have a picture, where you see here that it's in a location that's very close to the left branch of the vagus nerve. So when you get a posterior wall MI, you get hypoxia and you get irritation of the pericardium that surrounds it. And because the left branch of the vagus nerve, it's not exactly in this location, it should actually be on the anterior side of the esophagus. But when it comes down and comes around that area that's irritated and ischemic, that nerve becomes irritated itself. And that's a vagus nerve. And the vagus nerve has all sorts of roles in parasympathetic innervation and your digestive tract. And so it causes these symptoms of bradycardia, diarrhea, and lightheadedness. So inferior wall MI, consider those symptoms. So you have a chest pain in a patient with a low heart rate, history of diarrhea and lightheaded dizziness, think inferior wall MI. Is the USMLE going to throw that at you? Probably not. Usually an inferior wall MI, they'll give you an EKG and you'll need to just know what leads they're in. And I talk about in the when I talk about MIs and other lectures, I do talk about all the leads and how you can pinpoint those to your particular MIs. But suffice it to say, inferior wall MI, it's going to be leads 2, 3, and AVF. So this is your differential diagnosis of chest pain. We talked about a lot of these things. We just didn't talk about the psychiatric causes, but we talked about all these things, some of the things that are characteristic of them. I gave you sort of very characteristic findings for each of these, but in real life, it's never that cut and dry. You just need to know the characteristic findings, and you try to fit it to one or the other, but usually you're going to have 3 or 4 or 5 things on your differential diagnosis, and you'll make your plan to try to rule those things out or rule them in. But on the USMLE, they'll be pretty straightforward with you because you've got to choose one answer. You can't choose 5 answers. On your clinical case scenarios on step 3, you'll want to have a differential and then a plan that's geared towards each of those things on your differential diagnosis. So in summary, after taking into account the patient's age, physical state, the history, the physical exam, and the patient's risk factors, make a presumptive diagnosis. But in real life, you're going to have a list of things that you think it may be, and you're going to do certain tests to rule each thing out or in. But on the test, you need to know your most likely diagnosis, your number 1 most likely diagnosis based on all your findings. Remember the risk factors for an MI, so age, the presence of diabetes and hypertension, a past history of MI, a history of high cholesterol, smokers, fat people, stress, and illegal drug use, particularly cocaine. Your next step will almost always be to get an EKG since MI is the most deadly on the differential, and EKGs are easy and fast. Some exceptions, but I put stars here because in real life we pretty much get EKGs on everybody with chest pain. If the patient is young, under the age of 50 or 55, and has no risk factors for MI, you may not jump straight to an EKG. Or if the patient has very clear symptoms that point towards an alternative diagnosis. So they're 40 years old and they say, "Oh, I've got this burning pain and I just had, a ton of Mexican food before I came in here and, I feel like kind of nauseated. I got this weird taste in my mouth." That's reflux disease. Do you need to get an EKG? Probably not. You're still going to get one though. As soon as they say chest pain, EKG. That's how ERs work, at least in the US. But on the USMLE, if you've got a patient like that, you're not thinking EKG. You're going to be thinking, let's treat this patient's reflux disease. So, other things like if it's emergent, if the patient has a tearing pain and it's radiating to their back and they've got weak lower extremity pulses, in that case, you're probably not, even in real life, going to waste your time with an EKG. You're going to get a CT for aortic aneurysm and treat them immediately. Also, if the pain is not acute, if it's been going on for days, weeks, in that case, you might think costochondritis or something like that, history of injury. You may not jump right to EKG. But, I struggle to say this because, I'm trying to balance the test in which you probably wouldn't get an EKG right away on those patients with real life, where you pretty much always get an EKG on a patient who comes in with anything vaguely related to chest pain. But hopefully you can kind of find a happy medium between those and turn your brain on test-taking mode when you're taking the USMLE and then flip the switch on that and turn it on to real-life mode when you're working on the wards. With that, I don't have anything more for you. If you have any questions, please write me a note below.